Hello, my name is Dr. Paul Winston of Victoria, British Columbia, Canada, and the University of Victoria. I'm presenting on behalf of the Canadian Advances in Neuroorthopedics for Spasticity Congress Spirit. I would like to share with you our journey into discovering a new technology and a new technique to combat spasticity that we learned with incorporating techniques that we learned from our international peers. Here are my disclosures. And I cannot reiterate enough that this is the work of my incredible colleague, Dr. Daniel Vincent, interventional anesthesiologist who has passionately taken on this project and is truly the creator. If you're wondering where in the world is Victoria, British Columbia, it is on the west coast of Canada. It is an island about the size of somewhere between Belgium and Switzerland, or like the island of Taiwan. So most of us in medicine know what spasticity is. Those of us who are not in medicine know spasticity as a position of deformity of a limb where it's curled and tight in multiple positions, where you can't really open it easily or it's pulled tight. There's many definitions that people struggle with, but perhaps one of the definitions that we really need to consider is the following: that it's a disordered sensor motor control, meaning that there are different phases of tightness and stiffness in a muscle. In medicine, we always have to ask ourselves, are we learning or are we creating? Some of my favorite definitions of spasticity from Lynn Turner-Stokes and Jean-Michel Grassi talk about the vicious cycle of worsening spasticity, worsening changes of muscle architecture, which can lead to contracture. However, perhaps it doesn't always lead to contracture, and we're going to talk about today whether or not it really does. So I thought I knew a lot about spasticity. I treat it a lot, I read about it a lot, I participate in spasticity congresses, I've lectured a lot on spasticity. And after going to international congresses for years, I was blown away, as were my peers, by a presentation by Thierry Deltome from Louvain, Belgium, who is a brilliant physiatrist who has been presenting for years about his technique. And it was a technique that I'd never heard of before a 2016 Congress in Amsterdam, where he explained that they treated spasticity by actually performing neurectomies. So what they would do is do an injection of a nerve, in this case usually a branch of the tibial nerve. They would locate it with anatomical landmarks, stimulate the nerve to find the proper nerve and not just the muscle, and then paralyze it with a local anesthetic, such as lidocaine. If the muscle showed that it could fully reduce the angle, such as dorsiflex the foot, then they would perform a neurectomy of around 80% or more to allow the nerve to stop transmitting and the muscle to reduce. We found this to be absolutely extraordinary, never heard of it before, and the results and videos were breathtakingly good. My colleague, Dr. Rajiv Ribai of the University of British Columbia in Vancouver, invited Professor Deltome to come to Canada and teach us this technique. I began to read everything I could about nerve blocks, including these wonderful papers by Thierry Deltome, also Thierry Gustin, and there's actually 3 Terrys, so if you come from Belgium, the chance of having Thierry in your name seems to be quite high. The technique was, again, breathtaking, and it bared repeating, but where do you find a surgeon or a technique to do this? It's not easy to find people who want to participate in spasticity. So if A is for Ashworth, B is a better scale, the Tardieu scale. And Dr. and Professor Deltome would like us to revisit the scale to really understand how it's used. So most of us know about how to measure spasticity, but it really has that fast catch, maximum range of motion, as well as what the patient is able to do on their own if they have active movement. So if we look at a spastic limb, we have the fast catch and then the maximum range they can do. So fast catch, maximum range, or in the fingers, you would have a fast catch and maximum range of motion, or fast catch and no more. So Professor Deltome likes us to revisit this. So V3 is the fast catch, V1 is the maximum range of motion you can do slowly. And then we can look at the differences between the ranges and what they can do actively or what the caregiver can do passively. And this will really help us determine whether or not there's a contracture. So my colleague Rajiv Ribai also had me score an invitation to the first symposium of neuroorthopedics in Versailles, a neuroorthopedic congress, where I discovered that not only in Belgium but in France there was a robust program looking at this exact concept of neurectomy, but also muscle lengthening. It was breathtaking. The amount of knowledge there that was so advanced was hard to take because it was so advanced that what I'd seen in my North American model. But being at the Palace of Versailles with fireworks and a full music, I thought this is something that a physiatrist can do in one country, we should be able to export at home. I discovered that the French had a very large body of literature that they were producing in French on how to do surgical procedures for spasticity. Being Canadian, I am able to read French, as well as my colleague Dr. Ribai, and we began to really approach this from a systematic way and wondering how we could reproduce it at home. Much like Professor Deltome had published his beautiful work in multiple papers on the lower leg, Professor François Genet of Garches in France also had just produced with his team this beautiful paper looking at the most dominant muscles that were responsible for spasticity in the upper extremity. And in this case series, they found that the brachialis muscle was the most important elbow flexors in multiple cases. Of course, the brachialis is innervated by the musculocutaneous nerve, and you can also do a block of the biceps to see which is the most responsible muscle. So you basically locate the branch to that muscle using the diagram and anatomical landmarks, paralyze that branch, and see what happens to the limb. You know the French, they like to do things in a big way, so this was the finale of the Congress with music and fireworks, and really my inspiration to go home and recreate this. So it is possible to relearn. In 2011, when I was scientific chair of the CAPMNR National Congress, which was held in my hometown of Victoria, we invited Catherine Alter from the United States to teach us how to do ultrasound-guided spasticity injections. It seemed daunting. It took me years. But you can see here this white muscle is the branches or the bodies of the gastrocnemius muscle. The very thin one that we saw on the right of the screen is the lateral head, showing how thin it is. And having done ultrasound now for many years, I really began to love its exquisite ability to localize structures and improve my spasticity care. So you can learn. So while still in France, I called my colleague, Dr. Daniel Vincent, an amazing interventional anesthesiologist in practice for decades. And I said, Dan, we need your help to learn how to do diagnostic nerve blocks. However, we want to learn them with ultrasound, and there's really no textbooks for physiatry on how to do that. Could you teach us? He thought it was a great idea, and with a grant from one of our industry partners, we were able to cobble together 6 physiatrists from different cities. I do live on an island, so you have to fly there. And we had the 2 anesthesiologists in his office, and we thought, how are we going to learn to do nerve blocks? Would it be difficult? We had 4 patients in 2 hours to learn the technique. Since we had a great paper by François Genet, we decided to look for the musculocutaneous nerve. What's quite amazing is that on the left side here we see an anesthesiologist. We see his musculocutaneous nerve and the branching of his nerve to the brachialis muscle. Now, one of the things that Dr. Vincent always teaches us is that this is the neurovascular bundle. Big red, big blue, big yellow. And if you find the neurovascular bundle, you can usually find the branch of the nerve. Now, in a healthy muscle, there's healthy tissue surrounded by nerves. In a spastic limb that has been chemodenervated for years with botulinum toxin and spasticity and atrophy, it's a bit harder, but here we can see the nerves no problem. Now, this was one of my colleagues. She was deciding to perform one of our first blocks. Not even comfortable with ultrasound, but she was going to put in her needle. You can see the needle coming in towards that branch here, going down to the branch, the brachialis, and she's going to find that very easily, and then when she gets to it, she will inject her lidocaine and paralyze that nerve to the muscle. So this slide shows our first patient that we attempted a lidocaine nerve block with 2 cc's of lidocaine with ultrasound and e-stim guidance. We located the branch to the brachialis muscle. This is Dr. Rebai demonstrating the V3, the fast catch on the Tardieu scale, and showing that the V1, the slow movement, gets more range of motion, but of course he still has a maximum range of motion of approximately 142 degrees. So this is our very first nerve block. So Dr. Rajiv Rebai at the top is showing his V3 before the block, and on the bottom, which is characteristic of a nerve block, the V3 really disappears and you go right to the maximum range of motion. So our very first attempt at a nerve block using ultrasound was very quick, very efficient, and very functional, and we demonstrated that he had much greater range of motion than possible. However, he still had the same degree of range of motion and endpoint and presumable contracture. Now, while we were studying this technique and looking for its success, Dr. Vincent that very day said, well, if you're looking at paralyzing it with lidocaine, why not do it for much longer? You can get months to years of a nerve block using cryonerotomy. Now, I was very familiar with Dr. Vincent using cryonerotomy as he used it for many of my patients that had pain, but we had never heard of it being used for a motor function. So we decided to start looking at this, and we really discovered that thousands of patients have been studied for cryonerotomy in the pain literature, including headache conditions, thoracotomy pain, and multiple areas of the body, trigeminal neuralgia, etc. And one of the fascinating things about this technique for sensory nerves is you don't get that neuritis or neuroma that's long feared with other nerve procedures such as phenol, because you actually do not disrupt the epineurium and perineurium. You don't cut the nerve ending, so you don't get relief of neurotropin, which is felt to be belonging as a cause of pain. So the process of cryonerotomy involves placing a probe, just a needle through the skin, and it very quickly forms a ball of ice at -60 degrees using a gas to form the ice. And this causes myelin disruption and Wallerian degeneration of the nerve with axon loss. But what's really fascinating about this procedure, while you get complete disruption of the axon and myelin, this is a video from iovera.com from the iovera handheld cryonerotomy machine, not the one that we currently use, and you basically disrupt the axon. However, because the epineurium and perineurium stay, the nerve will regenerate, regrow, and reattach. And this has been shown in multiple series, both within rats and in sensory nerves, that it can regenerate and then reprocess. The length of time will really be the length of the nerve, so the longer the nerve at a millimeter per day, an inch per month, it will take to regenerate. Now, you can't just start freezing motor nerves without evidence, so we went to the literature and formed a systematic review with the help of our librarian from the College of Physicians and Surgeons of British Columbia. And we were able to initially find one article only on doing a fluoro-guided obturator nerve block to an adductor muscle in a patient with multiple sclerosis. That was all we could find. Much later, we found a proof of concept abstract from 2015, a very impressive article written by Paulin and Patel, in which they did about 15 patients in the musculocutaneous nerve. We had a published abstract, but not the publication itself, but it helped as a guide after we started the procedure. And there were several rat studies that showed that you could do motor studies no problem, and in fact the machines do have a motor setting. So as Dr. Vincent has done thousands of these procedures, which are deemed extremely safe, we decided to go with motor. Now, Andrea Trescott is the absolute pioneer in cryoanalgesia. She's written all the books and publications, currently residing in Alaska, and one of her papers had this lovely quote: "An accurate diagnosis with specific diagnostic injections of small volumes of local anesthetic and meticulous localizations of the nerve is critical for successful outcome." So we followed her guidelines, and this is our study. Now, going back in time, this is our very first nerve block. So the top is our first V3, and on the bottom, you can actually see we don't have that fast catch anymore. And I've already showed you this slide, but the lidocaine stops the catch. So Dr. Vincent performed our very first cryonerotomy on the same gentleman that you just saw in the previous slide. Now, he is about 9 days out of his cryonerotomy, and he hadn't thought of trying to stretch out the arm because, of course, he's had a stroke. He doesn't use that arm much. And we were quite shocked that he was able to extend to his V1 on his own. And you can just see that the V3 is gone, essentially, and the contracture that we thought was there is not. He no longer has a contracture. We presumed he did, but he doesn't. So if we look at his range of motion on the left side, we see his V3 at 97 degrees, and then his V1 at 142 degrees. After, it's very hard to actually pick up the V3, but it was about 112 degrees, and full range of motion 177 degrees for him. His Ashworth, of course, was significantly reduced. Now, at 2.5 months, his range of motion was getting better. He still has some clonus or shaking in that muscle. And at that point, I decided to continue with his botulinum toxin injections. This time, I did not inject the brachialis muscle, which we used for cryonerotomy, and I put more into the other elbow flexor, the brachioradialis, sparing his biceps so that he would have flexion function, and you can see he continues to improve. And you can see in the upright position, he has good range of motion. There's still some clonus, but by 4 months, it's actually kicking in the botulinum toxin that I gave him, and he's having better range of motion.
The arm up and down.
At 6 months, his range of motion is looking better and smoother, and he is really using it for a lot of function now. At 1 year, he is doing better, and I've put more botulinum toxin into his fingers to allow them to open more readily and loosely, and he's commenting that he is walking faster because he can swing the arm. He's able to mow the lawn. His arm is strong enough to pick up his grandkids, and he's quite pleased. Now, with the new procedure, we had to figure out a way to demonstrate it, so we came up with this graph, and on the top line, you can see that he has a pre-block, a V3 of 97 degrees after 110. The V1 did not change with the blocks. His active range of motion was 72 degrees, followed by 96. And then his Ashworth went from 3 to 2. Over time, his V3 became undetectable. His V1 was essentially full, and his active range of motion improved to 166 degrees from 72, and his Ashworth score went to 1+, so significant improvement. So the first day of our nerve blocks, we had a second patient for which we did a musculocutaneous nerve block, and we went on to do a cryonerotomy. So you can see on the top her active range of motion before the procedure versus 9 days post-cryo. She went up from 71 degrees to 114 degrees. If we look at her passive range of motion, you can see it's significantly better with knocking out the brachialis. However, you can still see her chest coming off the bed, and there's still some resistance to movement. So I thought perhaps we can do better. Thankfully, the incredible orthopedic surgeon emeritus, Dr. Mary Ann Keenan from Philadelphia, had published a very nice paper on phenol blocks for radial nerve to brachioradialis. So I was able to perform this using ultrasound guidance, and you can see by knocking out the brachioradialis muscle how much looser she is. Therefore, Dr. Vincent went on to perform a second cryonerotomy, this time to brachioradialis, and you can see how much looser she is and how her range of motion continues to improve. The real lack of getting it to full extension is most likely weakness. Now, we began to call back patients that had stopped getting treatment for years because they had plateaued and not got any better. So this young woman, I asked her if she'd be willing to try a lidocaine nerve block, and she decided to come back in, and you can see how much more easily her arm moves post-block. Her active range of motion is quite telling. She has quite a bit of clonus getting in the way of movement, and the arm is weak in extension, but it's better after the block, and she does have less clonus. So here we see her passive range of motion is very good. However, active range of motion is what patients typically want, but she already feels looser. When we look at active range of motion, the elbow opens more readily, but then she is experiencing clonus at the wrist or fingers, which is interfering with her function and not allowing her to use it fully. And at the 3-month follow-up, it's improving. You can see how passively it's so loose, but we have to address this clonus. So a simple physical exam notes that the clonus is mainly coming from the finger flexors, even more from the wrist. So the solution was I localized the median nerve at the antecubital fossa, performed a diagnostic lidocaine nerve block of the median nerve, and she's much looser. Now we don't need to perform a cryo there. We have botulinum toxin for the finger flexors and the wrist flexors, and you can see how the range is a little bit better. She can't extend again because of weakness of the extensors, but the clonus is much improved and it's not bothering her. And when I examine her after her botulinum toxin to the finger, the clonus is not there anymore and it's much looser. She really enjoys that her fingers will open more readily. Here's another example of a very stiff arm before a nerve block. You can see on the left how much resistance there is to movement. It's very hard to get the arm open, but after the musculocutaneous nerve block, it goes to full extension rather easily, and the movements on the right are both active, and this is passive right here. This is another example of a patient who has a lot of tightness in her fingers, so I'm demonstrating how supple she is with the musculocutaneous nerve block and how now I can pry her fingers open with one hand. It was extremely difficult before, and we've also knocked out the pronator teres, so it's easier to supinate the hand. Dr. Winston performs his cryo in the office, and you have an immediate partial effect because you immediately get disruption of the axon. It has not broken down, so it's not at its peak, but within minutes you have a result, if not seconds. 6 weeks after cryo, you can see how much better her arm is. It's much looser. We can feel a lot of resistance in her triceps. There's also some resistance in her brachioradialis. And our instructions to her treating physiatrist is to inject those muscles with botulinum toxin. And indeed, when she came in, I did a radial nerve block to brachioradialis, and you can see how much looser she is. So she likes that. And here's yet another example of someone who's had cryo for their musculocutaneous nerve, pre and post cryo. It's much improved. Now, while we were playing around with this technique, a beautiful paper came out by Alessandro Pacelli from Italy, looking at how to do a ultrasound guided nerve block to the tibial nerve. Here you can see my technique advancing into the leg, and I really want to make sure I'm stimulating just on the lateral gastroc here. And I'm putting in my lidocaine, and you see the disruption of the nerve so that the pulsation stops. I'm going to reposition and go to the next branch, to the medial gastrocnemius, stimulate to make sure I'm just there. The soleus is going along for the ride but not being directly stimulated, and I will paralyze that as well, period. I can use Professor Deltome's landmarks or Pacelli's, and I can pick off either the gastroc, medial or lateral head, the soleus muscle, tibialis posterior, or flexor digitorum longus. With permission of Alessandro Pacelli, I have used his landmarks as well as Dr. Deltome's. We have this plastered over our beds, and these are the landmarks to find the branches in approximate distances. The beautiful paper by Professor Deltome shows where to put this. And Alexis Schnitzler from France has a beautiful handbook that is available for free download that shows how to do anatomical landmarks for the nerve blocks, and we used that and synthesized it with Deltome and Pacelli. Again, they are aware of this, and we use this as our landmarks, and Dr. Vincent put together this slide. One of my colleagues approached us with a patient who was pregnant. She already had 2 young children at home with a diagnosis of multiple sclerosis, and she could not wear her ankle foot orthosis because of swelling in the leg from pregnancy, and was having increasing difficulty getting along and around because of spasticity in the left leg. You can see on the left the difficulty with the step-through gait. On the right side, immediately after her cryo, she is walking better. It is a ball of ice. There's no reason why it cannot happen in pregnancy. About a month later, she came back to clinic. She's walking better. You can, of course, see the weakness in the left foot. Some people might also notice the inversion movement. This could be corrected with a splat tendon transfer, but someone who's about to deliver does not want to undergo surgery. And 10 months after the procedure, with her AFO on the left, she's able to walk quite well. In fact, the brace needs to be adjusted as it's hampering her. And barefoot, she's able to walk well. It's not a perfect gait, but she is happy for the meantime with her life as it is. So with our first few cases, we did publish a how-to guide to cryonerotomy, as we're hoping that Menti centers around the world, particularly in the United States, have abundant access to cryonerotomy, more so than in my country, and we were hoping that people would try this for themselves with our guide. This patient has had numerous procedures on the leg. There's been a botulinum toxin, there has been an Achilles lengthening in the past, but still the foot drags. And you can see with the lidocaine block, the range of motion is actually improved. Not only does he have better passive, but active range of motion, and there is less clonus as well, period. And here is the active range of motion demonstrated after nerve block. And as in the case of most patients, it takes them a while to learn how to motor plan, as they have not done this movement in quite a while. Thank you, Professor Deltome. Rather than go for surgery, as he's had surgeries before, we performed a cryonerotomy, and you can see that the range of motion again is improved, both actively and passively.
That's good. Up and down.
Now, the French have published widely on different nerve block techniques. This was our first pectoral using ultrasound, and you can see my probe going in to where the nerve is to the lateral pectoral branch, and we are going to perform a lidocaine nerve block and a spastic pec muscle. One of our patients with incomplete quadriplegia, but with very minimal movements in the arms and legs, was really incapacitated by severe tone, a lot of botulinum toxin, plus 100 milligrams of baclofen, and still had spasticity. So we performed nerve blocks to see if there was a reducible range of motion, meaning we could achieve much better range of motion than we thought. And of course, we did this in a bilateral fashion. Dr. Winston performed bilateral pectoral cryonerotomies, and we were delighted to see that the range of motion was quite reducible, and he was able to achieve much greater range of motion. Now, of course, there's significant weakness, being a quadriplegia. However, for the caregivers, the positioning was really much looser and made function much better. What was also quite key in this patient, where we were basically eliminating a peripheral nerve. My colleague, Dr. Emily Krause, who is our peripheral nerve surgeon who's performing our neurectomies, had previously done an axillary nerve transfer. So she took the axillary nerve from the deltoid and implanted it into the triceps, allowing our patient to have more elbow extension. Because of the severe spasticity, though, and the arm in the closed-packed adducted position, he could not use it very well, and the combination of giving a nerve and taking a nerve improved his function. Now, we've been exploring how to use these nerve blocks to create function. So because his hand is quite tight, I performed an ulnar nerve block at Guillen's canal, and it allowed him to have better range of motion in his fingers, more active movement, because of the interossei were paralyzed, but you can still see that there's weakness because of the spinal cord injury. So we put on our extremely inexpensive Amazon.com TENS machine to the finger extensors, and he is learning to program on his own how to use those extensors. More surgery, stay tuned. I had previously mentioned that we can do median nerve blocks in the antecubital fossa. The median nerve, we all know, is very close to the pulse in the forearm, and you can see me going along here with the needle, and we're just going to lie lidocaine along that nerve to perform a nerve block of the area. I just wanted to show you the cryo probe of Dr. Vincent, this long line going in towards a targeted nerve. Now here's yet again a nerve block of a patient who has a spastic catch, found the arm to be very stiff and did not swing when walking, and how better he was during and after a lidocaine block. His carrying angle before and after the block.
This is Thomas, post-cryo, about 15 minutes now. Active movement. That's almost normal for you. Can you, with your other hand, move these fingers? Show us what you can do for extension.
Before it was in a ball, it was nowhere near being able to do this.
Little finger now?
It's been broken, it doesn't make
Yeah, don't worry too
much. But it's been
So we had been quite hesitant to
Post-cryo,
do
about
a
15
median
minutes
nerve
now.
cryonerotomy because it
Active
has a
movement.
motor and sensory branch. But in this case, the patient felt that he really had no sensation in the arm from a
that's
stroke. And
almost
after
normal
several
for you.
lidocaine nerve blocks, he felt
Can
no
you, with
dysesthesia.
your other hand,
So he
move
also had
these
no
fingers?
active range of
Show
motion
us
in the hand
what you can do for
after the
extension.
nerve block. So Dr. Vincent did a cryo to the median nerve just to relax the hand.
before it was
Now
in
it's
a
very
ball,
important to
it was
understand
nowhere
if you
near
do a
this.
median nerve block of the hand,
Little finger
you can
now?
open the hand and figure out whether or not the patient has active range of motion.
Yeah, don't
Because
worry.
if you do a median nerve block in a high fashion, you will still have your ulnar
Thomas,
intrinsics. So the
post-cryo,
patient will
about
still be able
15
to use
minutes
their
now.
lumbricals and their
Active
interossei
movement.
to close these two fingers. So we actually asked the patient after a median nerve block, can you do
that's
this or not?
almost
If they
normal
cannot do
for
that,
you.
it means they don't have
Can
active
you,
motor
with
function.
your other hand,
If they
move
do, then I
these
pass it
fingers?
on to my surgeon,
Show us
who will
what you can
selectively
do for
do
extension.
a microfascicular neurectomy to only the flexor digitorum superficialis muscle and spare the flexor digitorum profundus to allow them to have active range of motion, but that's another video.
It's been broken.
And we have decided that these are the main branches at this point that we will target for cryonerotomy, as in general they are large, easy to find motor branches that don't have sensory components. Dr. Dan Vincent is using this machine. It's an older model device. We are trying to import, with Health Canada's permission, a newer model. The components of a cryonerotomy machine, including the thermal insulating catheter, which will be injected into the skin. This is what the machine looks like and how it's used. Here is the schematic of what a probe consists of. Here, Dr. Vincent is demonstrating how he forms an ice ball just by putting into some saline. And you can see in the video here that as the gas goes in, we see the ice ball form. He pulls it out before it gets too big to leave the tube, but it forms very quickly, and it also dissolves very quickly once you stop the gas. And typically he will form an ice ball of about 8 millimeters by 6 millimeters. And here is the length of the probe that will go through a catheter into the skin. And here's another picture of the probe on ultrasound going towards the nerve. A very small amount of lidocaine is put on the skin to numb the probe going in. We don't want the lidocaine to interfere with the stimulation. As with all nerve blocks, you want to stimulate at the absolute most minimal stimulus possible. 0.8 milliamps is a very good one to make sure it's the nerve and not the muscle being stimulated. And here's one more view on the nerve being targeted. We cannot really describe again that these patients have fibrotic muscles, so you have to get very comfortable in localizing the nerve. Putting the ultrasound on the Doppler feature will show you where those blood vessels are if you cannot find where the nerve is. Therefore, positioning of the patient is very important. Pre-planning everything you will need is also crucial. Thank you to listening to our journey. It is Paul Winston on the left, Dr. Daniel Vincent on the right, and Dr. Emily Kraus, our peripheral nerve surgeon, who is instrumental in our techniques as well, and the three of us choose which procedure each patient will get. Thank you so much for listening. The following slides simply go through some of the techniques that we use and our literature review. You can read at your leisure.